right, well, good afternoon, everyone. Welcome to today's webinar, Coverage and Access Issues Affecting Women Living with Autoimmune Diseases. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research, which is a more than 30-year-old national nonprofit dedicated to promoting research on biological sex differences in disease and improving women's health through science, policy, and education. And we're convening today's event as part of a 4-part webinar series to bring attention to the impact of autoimmune diseases and conditions on women. Our last webinar, which was held in January, launched SWHR's Autoimmune Policy Agenda, which was created in response to the disproportionate impact these diseases and conditions have on women. Today's webinar will focus specifically on the coverage and access issues affecting women living with these diseases and conditions, and discuss how changes in policy could play a role in improving outcomes. Before we move into today's program, I'll just go through a few details and housekeeping notes. First, we'd like to thank Horizon Therapeutics for sponsoring today's program. Please note that today's web event is being recorded and we will post it online. We will send out the recording and any resources that are mentioned in the follow-up email to all registrants. To ask a question to the panelists during today's event, please use the Zoom Q&A function at the bottom of your window. You could alternatively use the chat function, but just know, personally, I think the Q&A is a better way to go. We will ask questions at the end of the event following all of our panelist presentations. And if you need technical assistance, use that chat function, and note that we have limited technical assistance available, but we will do our best while we are running the webinar. And with that, I would like to welcome 2 incredible panelists who will provide a primer on the coverage and access issues affecting women with autoimmune diseases and conditions. What steps have been taken at the federal level to curb the impact of these policies, and share what steps we as a nation could take to improve upon these policies. Sarah Buchanan is the Director of Federal Government Relations and Health Policy at the National Psoriasis Foundation. She is responsible for identifying and pursuing federal issues of significance to individuals with psoriatic disease, developing policies and resources to advocates on these issues, and representing the NPF in federally focused coalitions and before federal policymakers. In addition to advocating to federal policymakers within Congress and the agencies, she also advocates directly with the private insurance sector and other allied stakeholders to improve policies and advance the health and wellness of the psoriatic disease community. And Anna Hyde is the Vice President of Advocacy and Access at the Arthritis Foundation. She oversees both the federal and state legislative programs in addition to grassroots engagement. Her focus is to raise the visibility of arthritis as a public health priority, build support for federal and state legislation that ensures access to affordable, high-quality healthcare, and enhance patient engagement in the policymaking process. Anna previously served as Senior Director of Advocacy and Access, managing the federal affairs portfolio and overseeing the state advocacy team. And with that, I will turn it over to Anna, who will give our first presentation. Thanks for joining us, Anna.
Hi, and thanks for having me. I am going to take a second to share my screen so I can put some slides up here. And bear with me, I know this part always takes a minute. From the beginning. Okay. So as Katie said, my name is Anna Hyde. I have been with the Arthritis Foundation for going on 9 years now, and that entirety of that time, I have connected with patients on a daily basis in one way or another. So I love talking about these kinds of issues because there are some issues that we'll kind of go through today that just seem to be kind of persistent. And being able to track through surveys and focus groups and talking to a lot of the same patients who engage with us all the time over the years really puts a fine point on that. So I'm really happy to just sort of be able to bring some of those points to you today. I'm going to go through a couple of lanes here, one on cost barriers and one on coverage barriers that of course are interrelated, but I just want to put some kind of data points here that I hope will help shine a light on the issues and then the solutions. And I know Sarah will go a little bit into greater detail about some of the legislative solutions. And I certainly welcome questions in the chat or however else we'll be accepting questions at any point throughout. But just general landscape, these are not, the general landscape here is not AF data, but it's data that we've pulled in recent months from various places that kind of show what the trend lines are in the health market right now. So in thinking about cost, something that comes up often, in conversation is, well, people are choosing health plans that tend to be higher cost, or they should choose health plans that are in, lower deductible, or don't choose the high deductible health plan, or things like that. And I always like to come back and say, well, not always do you have a choice. If looking here, about a quarter of covered workers to its employer market have plans with out-of-pocket max of over $6,000, and that certainly includes deductibles, copays, premiums, and that sort of thing. But just putting sort of that point on how exorbitant health costs can be, even if you are insured, fully insured. High deductible health plans, I feel like a lot of what both Sarah and I will talk about when it comes to cost barriers really sit in this space. These folks are particularly vulnerable for experiencing sort of negative impacts from cost. Dollar amounts of high deductible health plans are rising and have been for over a decade now. And you see here the numbers. I don't need to necessarily go through them, but these are just, in the thousands of dollars we're talking about. And the number of people enrolled in high deductible health plans is rising as well. And the number of people who don't have a choice, where there is only a high deductible health plan offered to them. So they don't have a choice but to pay that $2,000+ deductible. And then, so to kind of put all of that together, what does that mean for the average family? And so here, median spending on healthcare was over 11% of household income in 2021, which is a pretty exorbitant number, I think. And this is sort of averaging out anybody in an employer-sponsored plan. So, if we isolate the chronic disease patient, it's likely going to be more because they're utilizing the healthcare system more. So putting this down to the arthritis landscape, say we support and represent people with arthritis, all the forms of it. But I think that a lot of what arthritis patients experience is pretty common across therapeutic areas in the chronic disease space. So I kind of use sort of chronic disease patient and arthritis patient interchangeably a lot of times. But we do surveys every single year. And we actually did a longer form survey just last year. So this data is still pretty fresh, trying to get a sense of what are the top challenges that you experience in your healthcare, not just cost and insurance coverage and things like that, but also just care coordination, anything around social determinants of health or environmental impacts that create barriers to care, things like that. But on the cost and coverage side, the top barriers here on the cost side were high deductibles, accumulators, which we'll talk more about in a minute, and then high co-insurance, which we will also talk more about in a minute. So, really tracks with some of that outside research. And then 37%, I think this is the really critical point here, 37% have trouble affording their out-of-pocket costs in the past year. And of those, more than half have incurred some sort of debt or financial hardship because of it. And that has obviously a compounding effect, because when you're experiencing things like that, it increases rates of stress and anxiety. So there's a mental health component to it as well. And we also see a strong mental health component with just symptom management itself. So that just, I hope sort of the picture that I'm weaving is one of this kind of snowball effect that can happen. So top coverage challenges, general landscape, again, sort of broader data. 43% of working age adults were inadequately insured in 2022. I remember reading that last fall, and that really just popped out to me. I sort of think about, underinsurance. Nearly a quarter of those who were underinsured, so that means their coverage didn't provide affordable access to care. I think the previous slide maybe shed some light on that. But there are some other things as well, I think, that kind of come into this. You're not necessarily underinsured if you're experiencing kind of health coverage protocols that ultimately delay care or things like that. However, I would, there's a lot of parallels between some of the coverage barriers and underinsurance that I think can also be thought of a little bit interchangeably. For example, this next bullet point, 46% of respondents had delayed or skipped care as a result. We see that often with some of the utilization management, inappropriate use of those protocols like prior authorization and step therapy, which we'll go into here in a minute. And I also wanted to kind of shine a light on the use of specialty tiers and creating a set of coverage challenges that we're increasingly seeing. Specialty tiers are formulary tiers that tend to have specialty drugs, a lot of biologic medications that are used to treat rheumatoid arthritis, psoriatic arthritis, and other forms of autoimmune disease. Tend to be in specialty tiers, and the specialty tiers tend to have co-insurance or higher cost sharing. And what we're seeing more and more of lately is all of the drugs for a particular condition being placed in those specialty tiers. That can cause problems for patients because they do tend to have higher costs. Sometimes you have to go through more requirements like prior authorization to get those therapies. And increasingly, we're seeing co-insurance tied to specialty tier drugs. And co-insurance, so as opposed to paying a $50 copay or whatever it may be, you're paying a percentage of your drug, and it tends to be based on the list price, not the negotiated net price. And if you look through just state exchange plans, federal exchange plans, you'll see that average co-insurance rates are not insignificant. 25% is kind of on the low end these days. You'll see up to even 40% and above. So if you're thinking about a multi-$1,000 list price drug, and then needing to pay a even 30% co-insurance on that, you can start to see how care becomes unaffordable and how these coverage and cost barriers are related to each other. The arthritis landscape are that same survey I mentioned a few minutes ago. We asked what the top barriers to care are. Insurance not covering certain services or treatments was part of it. And that's not specific just to medications. It can also have to do with certain provider services like physical therapy, out-of-pocket costs, and then step therapy, which Sarah will talk more about here in a few minutes. Prior authorization, I wanted to shine a light on here because it comes up as our top arthritis care-related challenge on our annual advocacy survey that we do every single year. And oftentimes what we're seeing here is you are prescribed a drug, you have to receive prior authorization from your insurance company before you can access that drug. That's not necessarily inappropriate. I think, one point I would certainly drive home is that there is a place for utilization management requirements like prior authorization. Where it becomes challenging for our patients is when they have to go through prior authorization multiple times for the same drug, sometimes multiple times within a year, and or it can take a while for the prior authorization to be approved. So that's sort of where I want to focus there. Okay, so what is the impact? Our surveys that we've done track really closely with outside research around the impact that it can have. Here, we talked about this a little bit already about the amount of hardship, financial hardship, but really, I think the through line here is what happens next. Oftentimes, it leads to delays in prescription fills, sometimes, unfortunately, abandonment of therapy. And when you are a chronic disease patient, maintaining your treatment regimen is really critical to maintaining your health. And when you aren't able to do that, some of these conditions can be degenerative. It can cause other health outcomes. It can cause hospitalizations, infections, all sorts of things that we really want to avoid. And really, having to abandon your therapy certainly is not clinically advised. So outside research backs this up, of course. And there was a health affairs study last year that I point to often about the relationship between those with subsidies and not having subsidies among Medicare beneficiaries. And the non-initiation rate of therapy was considerably higher for those who did not have subsidies. So that again shows that relationship between cost and treatment adherence. And I think the through line here across any stakeholder is that we all want patients to be adherent to treatment. So sort of keeping that as the North Star. I'm always sort of thinking backwards when we see protocols or healthcare policies or other things like that. Does it have an impact on patient adherence? If so, let's take a step back and think about how to avoid, sort of non-adherence. I want to spotlight for a second accumulator adjustment programs, which we talked about a few minutes ago, because this is not a term that rolls off the tongue. It's not certainly not a household term in my house, but it's a practice that's been growing for the past about 5 years, so relatively new in the grand scheme of things. But really the idea of it is that if you rely on copay assistance, that could be from a third-party charity, it could be from the manufacturer itself of your treatment. If you rely on copay assistance to help afford your out-of-pocket costs, which I think we've already talked at length about why many patients might need to do that, your copay assistance is not counting towards your overall out-of-pocket exposure if you are in an accumulator adjustment program. So what that means, if you are using a copay card to afford your medication, and you go to the pharmacy counter and you use that copay card to pay through your deductible and other kind of copays, at a certain point, that cost sharing assistance is going to run out, will be exhausted. These are not limitless programs. When that happens, you go to the pharmacy counter expecting to be able to pick up your medication like always, and you're told by the pharmacist, well, you have exhausted your copay assistance and now you need to pay for the full cost of your drug through the deductible or whatever your other cost sharing requirements are before you can access this. Unfortunately, we've had all too many stories from patients, including just one last week, about someone who was going through an accumulator. They were not able, because they were in a high deductible health plan, to afford the out of pocket for that therapy. They ended up having to switch drugs. And unfortunately, this is not one that has a sort of a happy ending. The drug has not been working as well for this particular patient. And she's finding herself in a bind. What do I do next? I'm starting to have kind of reemergence of some of the symptoms that were kept at bay with the drug that my doctor had prescribed for me, that sort of thing. I think one thing that's really important about this is that you've already gone through prior authorization, step therapy, whatever other protocols are required by your health plan to get your drug. Your drug has already been deemed appropriate to utilize. And then to be told after all of that, that you must pay through the full deductible, despite the fact that you may be on a high deductible health plan and with a specialty tier medication that requires co-insurance. So again, we're talking about thousands of dollars that are just really not available for the average healthcare consumer. What are you supposed to do? And patients have told us in multiple surveys where we ask questions about what would you do if faced with a high unexpected charge. I would delay the fill. I would call my doctor, ask to be switched to something else, or I would just abandon the prescription altogether. All of these are kind of worst case scenarios in our mind. We do not want patients to have to go through that. I'm not going to go through this in great detail because I know Sarah Buchanan has a lot to say about step therapy as the co-lead of a coalition dedicated to this issue. But just in RA specifically, Avalier data, this is something that we use often, kind of shows the growth of step therapy. And so step therapy, also known as fail first, means that your doctor may have prescribed you one medication, but your insurance company wants you to try a different one before you can, and have to potentially fail that drug before you can get access to the drug that your doctor prescribed. Where this gets really tricky for our patient community is that it often takes 2 to 3 times trying different therapies to find one that works for you in the first place. It's a very delicate balance. And it's not like if you're trying a therapy, a biologic medication, and you're finding that it's not working for you, you can just stop and the next day start another one. You have to, there's a whole cycle that takes place before you can switch between drugs. All that while, your disease progression could be kind of in play. You could be experiencing joint damage. These are, autoimmune diseases are systemic. There could be organ damage, other things like that, that you want to be able to control early on in these kinds of diseases. So there's, of course, a negative health impact, but also negative financial, emotional. We talked about that a little bit already. And then surveys that we've done are also back up this, 50% of respondents were required to try 2 or more drugs. So it's not always that you are required to just go through one step. Sometimes it's 2 or more before you can get to the one that your doctor prescribed. And then prior authorization, which we've already talked about, but I just wanted to put this survey stat because the AMA does these surveys every so often, asking their members, providers, how prior authorization is impacting their practice. And this was kind of an eye-popping number to me. It's not just that prior authorization is causing difficulty for providers and of course then for patients, but it's for 34% of physicians reported that it's caused serious adverse events in patients. So you're seeing that health impact with inappropriate utilization of prior authorization as well. And this slide just gives some quotes that we pulled from story banking and from doing focus groups and open-ended surveys around what this really means. And I won't read through them all, but I'll just go through perhaps the shortest one about, a person with juvenile arthritis, kids get arthritis too, who had to go through prior authorization, and the difficulties that they had led to trade-offs that they as a family had to make. Which is really unfortunate and not something that we ever want to see. Unfortunately, these stories are also common. I have more of them than I care to have. And so we have really been looking for what are the solutions, and there are solutions at the federal level. Certainly, most of these issues also have analogs at the state level. And so, like I said, Sarah Buchanan will go into greater detail here, but the Help Co-Pays Act was just reintroduced last night. So this is hot off the press, HR 830. We have a bill number and everything. This would ensure that those that cost sharing assistance that we talked about, those accumulator adjustment programs that prevent cost sharing assistance from counting towards copay, that would not exist anymore. That cost sharing assistance would count towards patients' out-of-pocket liability. It also closes a loophole in the essential health benefits that also causes some issues for patients. So that's certainly something that members of Congress can support. The Safe Step Act would reform step therapy. Sarah will talk about that a little bit more here in a minute, but it just puts common sense guardrails around it. It doesn't say the practice can't exist, just put some guardrails to make sure that it's not impacting patients negatively. And then the Improving Seniors Timely Access to Care Act does a similar thing, but for prior authorization. So those are some of the specific opportunities. From a broader standpoint, we sort of feel like, all right, there are all these things going on. You got prior authorization growing over here at step therapy, and now we have these new things, accumulator programs, and these out-of-pocket costs, and the ways in which patients are being asked to pay more for their care is just growing. Let's take a step back and put it all together. What is the relationship between health plans and PBMs and the practices they're putting in place to control costs? And not wrongly, everybody wants to control costs, and then patient outcomes. Are we still meeting that purpose of achieving the patient outcomes that we want to achieve? Like, let's take a step back and really investigate that. We would love to see more of that kind of holistic sort of investigation of how all the pieces of the healthcare system are interacting. And then working with the patient community on value-based care solutions. Value-based care is certainly a buzzword, and there are many different ways to think about it, both big and small. We are very invested in this space of making sure that all healthcare is delivered with value to the patient in mind. Does it meet the patient goals and their preferences and what they want to get out of their healthcare? And prioritizing that is going to help the long-term health of the patient, but as a result, also the long-term health of the financial sort of components of healthcare as well, to the system as a whole. That's sort of the point that we like to drive home. The more you can get a patient onto therapy quickly and continuous on that therapy over time, the lower the healthcare costs of the system will be over time. So that's something that we're trying to kind of put more emphasis behind, more data behind. We'll continue to do that, and we'd love to work with any and all stakeholders who are interested in doing that with us. So questions, my contact information is here. I am going to go ahead and stop sharing so that Sarah can tee up her slides, and happy to answer questions here. And I see one in the chat here, and I appreciate the comment. Would be happy to continue answering questions through the chat, but in the meantime, I will go ahead and turn it over to Sarah.
Great, thanks, Anna. And I thought that was a really good summary of how some of these utilization management and access barriers impact patients and how common they are. So I will discuss what the opportunities are in Congress to address some of these issues, and also what to look out for in some of the agency efforts as well. So first, I'll start with just aligning on the terms. Utilization management, I consider it an umbrella term that covers any tactic plans put in place to try to limit costs. Underneath that, you have prior authorization, which is a form of utilization management in which providers and patients have to seek approval by the health plan before that health plan will agree to cover a certain service or prescription drug. Step therapy is a complex form of prior authorization in which patients and providers have to seek that approval from the plan, but the plan tells them that that patient has to try and fail on one or more drugs that the insurer prefers before the plan will cover the treatment initially selected by the patient provider. So again, utilization management, or UM, is a broad umbrella term that encompasses both prior authorization and step therapy is a complex form of prior authorization. I became really passionate about trying to improve utilization management policies to better serve patients because of the patient stories that I hear. And just like Anna, I've been speaking with patients and providers for years, and unfortunately, there's many of these stories. This one just came out. Carolyn Johnson is a journalist with the Washington Post, and she just published a blog post about her experience with step therapy. Her son at 3 years old got diagnosed with a rare condition, and a provider recommended they try a complex medication that's proven to work for children with this condition. And their health plan required them to try and fail on either ibuprofen or steroids. There's no way ibuprofen was going to work for this child. Steroids is a terrible thing to give to a child long term. The mother, Carolyn, wound up patching together certain free drug samples or extending the doses, so limiting how much she was giving her son so that she could extend the medication longer for him until she finally got an approval for a treatment that the insurer would cover. And that treatment was even more expensive than the initial treatment the provider and Carolyn initially sought approval for their son, which is just mind-blowing. So give the story a read. I linked to it on this slide, and it's stories like these that really motivate us to take action, because no mother should have to watch their child suffer for 2 months, especially when they're in a developmental stage. These kinds of delays in treatments, I mentioned it took 2 months before that child could gain access to a treatment that would work for him. These kinds of delays can lead to severe or irreversible health outcomes. So in the case of psoriatic arthritis, which is a form of psoriatic disease, delays in care can lead to irreversible joint damage, which is pictured on this slide. And we do have many stories where patients walked away from a step therapy protocol requiring surgery to remove a colon, or with irreversible joint damage, or in some cases, patients have died because they just couldn't get through the barriers to get access to the treatments that work for them. This really shows not only, we've talked about the breadth of these utilization management protocols, but it really shows how deeply harmful they can be for patients and their families. Psoriatic disease, by the way, affects 8 million Americans. It includes psoriasis and psoriatic arthritis, and these are considered immune-mediated conditions. Anna did a really good job providing some high-level stats, so I'll keep this part short. But I did want to share some research articles in case you wanted to learn more about the data. Step therapy has been estimated to be applied to about 40% of drug decisions in commercial plans. More than half of those step therapy protocols were more restrictive than the FDA labeling, so they were not based on medical evidence. And this study also found that there's a lot of variation between health plans. So the treatment that you're able to gain access to really varied by which plan you had, and it was difficult for patients and providers to predict. Utilization management in general, including prior authorization and step therapy, was also found to cost the healthcare system $90 billion annually. And part of that cost was how much providers are spending to hire staff to try to appeal and combat these medically inappropriate utilization management protocols, or how much patients are spending out of pocket to maintain continuity of care when they're waiting for a coverage decision for months, or even how much health plans are spending applying utilization management and enforcing it and dealing with all of the patient and provider appeals. This last bullet really covers some disease-specific consequences of utilization management when it's misapplied to patients and not resolved in a quick manner. So a major bill that the patient and provider community is working on is the Safe Step Act. This bill addresses step therapy in employer plans, and I like to say it does three things. It ensures that employer plans offer a step therapy exceptions process so that if a patient and provider feel a insurer preferred drug would be medically inappropriate for them, they can seek an exception. It requires plans to respond to that exception request within 24 to 72 hours. So 24 hours for emergencies and 72 hours otherwise. And it also establishes no-brainer circumstances when a patient should be granted an exception. So I was talking to somebody the other day that was actually surprised that health plans apply step therapy to stable patients. So the patient had already gone through a long, exhaustive effort to find a treatment that worked for them. And even after that, plans may make that patient stop their treatment, get off of it, and try and fail other treatments before providing coverage again for a treatment that was initially working for them. So that's a circumstance, is if the patient is stable, then they shouldn't be required to go through step therapy again. If a patient has already tried and failed the drug, they shouldn't have to be required to try and fail again. If the drug would interrupt their ability to work, so say the patient is a truck driver or a pilot and the drug would have side effects that would make it difficult for them to use heavy machinery, then that patient shouldn't have to fail on that drug if there's another available that wouldn't have those consequences. What I love about this bill is it's very bipartisan and very popular in both the House and Senate. A lot of our sponsors are doctors themselves, Wenstrup, Ruiz, and Marshall. And I just love the Republican-Democrat partnership we have going on here. Last Congress, the Safe Step Act was referred to the Education and Workforce Committee and Help Committee. It's not yet been introduced this Congress, but it will be soon. These images are of Representative Virginia Foxx and Senator Sanders, who are now the chairs of their respective committees. Last Congress, this bill had broad bipartisan support, almost 200 co-sponsors in the House and Senate, as well as almost 200 co-sponsors in the House, almost 40 in the Senate. Good mix of Republicans and Democrats. And then I also really appreciated that the Republican Healthy Futures Task Force came out with recommendations that really aligned with the goals that we're trying to see with the Safe Step Act, which is to grant timely access to care for patients. So all of this bodes well for our ability to advance the Safe Step Act this Congress. The Safe Step Act is actually based on laws that have been passed and refined in the states since 2012. So 36 states have passed step therapy reform laws. They're all the green states in this map. It's important to note that these state laws apply to the small group and individual health plans, but they don't apply to self-insured employer plans. So the Safe Step Act, which is very similar to the state step therapy reform laws, would extend those protections in the states to individuals with employer plans, including those with self-insured, which is a big chunk of the American population. Many of us, including me, get our insurance through our employers. So for example, right now in Texas, the state has passed a really strong step therapy reform law, but if you have especially a large employer providing insurance in Texas, those people in Texas aren't currently getting the protections unless we pass the federal bill. Another thing we've learned from the states is the step therapy reform law's impact on premiums. I think Anna made a really good point, rightly so. The patient community also doesn't want to see rising premiums or higher healthcare costs, but they do want good access to the care they need. And what we were glad to see is that there's really no difference in the rate of change of premiums in states that have passed step therapy reform laws versus states that haven't. So this orange line tracks the rate of change for premiums in states that have passed it, and it's actually beneath the blue line. So it means that this orange line, the states that have passed step therapy reform laws, their premiums have either grown less or decreased more than states that haven't passed these laws. In general, though, this isn't statistically significant. So the point here is that there's really no difference between premiums in states that haven't passed it and premiums in states that have, which for me is a really good news situation where you can improve patient access to care without really impacting costs. This is my last slide on step therapy, but I did want to flag a bunch of recent articles came out in this past month. So this top one, Need a New Drug by Rachel Zimmerman, was just published in the Washington Post this week, and it provides a really good overview of what patients and providers are experiencing when they're subject to step therapy protocols that are medically inappropriate, and some of the work that we're doing to try to fix it. This article I wrote about high-priced drugs was Carolyn Johnson's blog post about her story with her son. So you can read through that further if you'd like to see it. I'm sure we could send these links out. And this last article about United Healthcare tried to deny coverage is another just devastating patient story that goes to show how hard patients have to work to, try to get their health plans to do the right thing and cover the treatment they need, like they're legally obligated to do. So again, this is just additional reading for you. And I just find these stories so motivating to try to pass things like the Safe Step Act and the Help Copays Act and address these issues. The next bill I'll cover is the Help Copays Act. Really excited. It was recently introduced. Congratulations to that coalition. That's a really big deal. So we're glad to see it already hit the ground and advocates can hit the ground running with this one. Again, this is another bipartisan bill with sponsors in both Republican and both sides of the aisle. This bill, as Anna already summarized, would ensure that copay assistance counts towards the patient's cost sharing, so their deductible and out-of-pocket max. And it would close a loophole that currently allows employer plans to just decide not to cover treatments. What a genius idea. We can save money if we just don't pay for it. Unfortunately, that really causes patient harm. So glad to see this bill in the books in Congress and hopeful to gain more co-sponsors for this. Again, another reason this bill is so important, as Anna already mentioned, is that many in the patient community just can't afford $6,000, $10,000, $20,000, whatever their out-of-pocket max is, year over year over year, just for their chronic disease maintenance. So if they're able to get patient assistance, third-party patient assistance, it should really count towards their deductible and out-of-pocket maximum, because otherwise that basic prescription drug that's maintaining their chronic disease is just unaffordable for them. Just like the Safe Step Act, the Help Copays Act is based on laws that have been passing around in the states. So 16 states have banned copay accumulators, very similar to the federal law. Unlike the Safe Step Act, the federal bill applies to all commercial plans, which keeps it simple. And last Congress, it was referred to Energy and Commerce. I expect it will be this Congress too. A third bill I'll flag for you is the Improving Seniors Timely Access to Care Act. I always joke, I feel like Mugatu talking about this bill, because the advocacy community did a really good job advocating for this bill last Congress. And I always feel like, oh man, the Improving Seniors Timely Access to Care Act is so hot these days. So again, this is a great bipartisan bill. It includes some good doctors in the mix of sponsors as well. And what it did is it would establish electronic prior authorization systems for Medicare Advantage plans and require real-time decisions for routine care for Medicare Advantage plans. A limitation of this bill is it does not apply to prescription drugs. So it's a really important bill and it helps patients access medical services, but it doesn't really address prescription drug-related utilization management for patients. Last Congress, this bill passed the House, which was so exciting to see. And in December, CMS issued very similar proposed rules that they should be finalizing in the next few months that would basically do what the Improving Seniors Timely Access to Care Act would do. So at this point, it's unclear whether this bill will be reintroduced in Congress. So if it were reintroduced this Congress, it would be to codify those CMS regs into law. And if it is reintroduced, we're expecting a lower CBO score, which is great and should help its passage because CMS already made those changes. So the last thing I'll flag for you is to talk about pharmacy benefit managers, or PBMs. This topic has been really popular. It's been popping up all over roll call in the Hill because a lot of legislators and committee chairs are signaling that they want to work on this issue. So PBMs are basically middlemen. Health plans contract with PBMs to help them negotiate with drug manufacturers and also handle prescription drug formularies. There are some concerns about the way PBMs might be working, and it's a bit of a black box, so not very transparent and difficult to see. But some of those concerns is that PBMs may be encouraging spread pricing, where they're encouraging higher drug prices actually, so that they can negotiate a deeper rebate and be able to make money by paying less for the drug than what they're charging for it. Another concern is that PBMs might be making all this money and telling their, the plans that they're contracting that they're making savings for patients, but they're not actually passing those savings through to the patients. So those are some possible concerns with PBMs that Congress and the administration are exploring. So some things to keep an eye out related to PBMs. In June of last year, the Federal Trade Commission launched an investigation into PBM business practices, and all of our patient and provider groups submitted comments outlining the consequences of utilization management, step therapy, prior authorization, high out-of-pocket costs. So it'll be interesting to see what the FTC concludes with that, and hopefully they'll address some of these issues that I just discussed in this presentation. Many committees are planning hearings around PBMs, including energy and commerce, and there's lots of proposed bills related to PBMs covering the gamut from inappropriate business practices to requiring transparency. So all of this activity could present opportunities to discuss utilization management and high out-of-pocket costs as they go through this process. So in conclusion, I loved Anna's last slide because it really matches my slide. And I think it's just a good overview for policy issues that are impacting those with autoimmune and immune-mediated conditions. We're really hoping Congress will co-sponsor the Help Copays Act, which again was just introduced yesterday, which is super exciting. And that members of Congress will also co-sponsor the Safe Step Act, which should be dropped pretty shortly. And then legislators and legislative staff and advocates can also monitor other activities that might help to improve patient access and reduce cost sharing. So PBM policies are one thing, as well as keep an eye on whether that Seniors Timely Access to Care Act, which is so hot right now, will be reintroduced. So that concludes my presentation, and I'll stop sharing my screen and pass it back to Lindsay.
Thank you so much, Sarah, and good afternoon, everybody. My name is Lindsay Horan, and I am the Chief Advocacy Officer at the Society for Women's Health Research, and I am pleased to moderate the question and answer portion of today's event. Again, if you have questions for Sarah or Anna, please drop them in the Q&A box, and we will do our best to answer. I'll invite our panelists to come back on and turn their cameras and mics on so we can chat with you a little bit more. Again, just want to thank you both so much for your presentations. I think there are so many important nuggets of information that you shared within your presentations, and they were also really effective at shining a light on not only the health impacts that these policies can have on patients, but also the financial and emotional impact that these policies can have on patients. And I would also tip my hat to you both for pointing out that Washington Post piece from the reporter. It really does. It brings this issue to light in a whole new way. And I think, part of that was, this is somebody that writes about these issues for a living. And whenever she was trying to navigate them herself, she ran into issues. So it's a really important conversation that we're having here today. So taking it back to a higher level, we talked about the impacts of these policies on patients, but what are the implications of these policies on the healthcare system itself when patients are denied treatment or when they experience treatment delays?
Yeah, I'll start.
Yeah, go ahead.
And then, Anna, please backfill what I missed. So I think what's really interesting is that utilization management, when it's inappropriately applied, can actually increase costs. So a talking point is that utilization management is used to control costs. But what we found is that a lot of times when you look at, it's controlling costs if you just look at the prescription drug benefit, but when you look at the costs coming out of the medical side, because of all the consequences, extra hospitalizations, surgeries, other serious adverse events, it can actually increase costs. So that's one issue with the health system, is that it's misapplied utilization management that's not medically inappropriate, and when there's no good way for patients to seek an exception, can increase costs. It also increased costs to the health system because providers are paying full-time staff for dealing with these appeals, and patients are paying out of pocket or taking time off work to handle this. It reduces productivity and increased costs in that way as well. One last thing I'll point out before turning it to Anna is there's been a lot of discussion after the pandemic about provider burnout. And one major reason I hear from providers about why they're so burnt out is because it's frustrating seeing someone in front of you that you're responsible for suffering, and you know it would help them, but you just can't get access to the treatment because you're on the other line of a phone call with somebody else that has, just isn't working with you. So provider burnout, I think, is another consequence to the health system of some of these issues when, again, they're just misapplied.
Yeah, I totally agree with that. We hear often from providers, and I think the AMA surveys back this up too, that these administrative barriers are increasingly taking up chunks of time that obviously then take away from patient care, which is what providers got into the business in the first place for. When we're all dealing with provider shortages in rheumatology, we are very much so confronting that. That's a real problem. And I would go back to that same question that I asked at the end of my piece, which is, are these policies really serving the purpose they're intended to? Are they, because we understand the kind of talking points around, prior authorization and step therapy are necessary because health plans have the ability to stay up with the latest clinical guidelines and, medical evidence and things like that, and sift through all the scientific journals that are coming out all the time in all these therapeutic areas. But when they're inappropriately applied, as we all have, I think, hopefully made the case here, and I agree that Washington Post article is so powerful. It's kind of hard to see how you can kind of match those things up. And so having some of these reforms and guardrails in place, I think, can really help. The other thing is, I just don't think there is a lot of line of sight into the different books of business, which Sarah talked about a bit. The pharmacy benefit side, the medical benefit side, and even in the medical benefit side, you've got hospitals, you've got providers. They're all different, accounting lines. And so it's not always easy to get that total cost of care picture of the patient. When dealing with a chronic disease patient, that really matters. If you're not getting your prescription drug that you need on the pharmacy benefit side, you may very well end up in the hospital, which is going to cost a lot more. But the person at the other end of that expense sheet may not care or may not have that full picture. And so, the ability to kind of, again, take a step back, not just look holistically at whether these practices are impacting patients positively or negatively, but also the just sort of systemic, the whole, looking at the health system itself holistically to see how any given kind of patient impact impacting the stakeholder system as well, I think is important. One last point here, I feel the need to always say this, which is it is so critical to look at the consumer of healthcare differently than the patient of healthcare. I hope that our presentations made this case too, but consumer of healthcare may be utilizing the health system once in a while. You're getting your annual checkup, and maybe you need to go to the doctor once in a while when you're sick. But if you're a chronic disease patient, we've asked this question too: how many providers do you utilize to manage just your arthritis condition, not any comorbid conditions? And it's the average is like 3 to 4, and regularly, right? And so I think that matters too. Some of the policies in place to inhibit utilization of healthcare are inappropriate for someone who relies on utilization of healthcare in order to stay healthy.
Thank you both so much. And we have a comment in the chat kind of driving home some of the points that we made. This attendee said, I work for a health insurance company in the UM department. It's really hard being on this end as a nurse with psoriatic arthritis and a child with psoriatic arthritis. I know the issues, but I have to follow our protocol, and it's heartbreaking many days. So I'm sure there are many people that feel that same sentiment. One thing I'm curious about and would love input from the two of you. So do we see that any of the policies that we discussed here today, whether it's step therapy or prior authorization, have a disproportionate impact on certain populations of women, and kind of where do we see those differences? So I guess another way to frame the question is, are there elements of these policies that could actually contribute to health disparities?
I'll take this one first. I mean, certainly just by sheer numbers, there's an impact, because in autoimmune forms of arthritis, they do disproportionately impact women. So you have that disproportionate impact right off the bat. But I think, furthermore, there's a lot of research that's been done showing that women kind of disproportionately take on healthcare for the family, right? And so when we're talking about this administrative burdens in particular, and the amount of time spent, that the quote, it's like a full-time job, has happened so many times in focus groups. I'm like wondering if they're like, if the patients we talked to were like colluding with each other, like, did you use that same line? Because I feel like I hear that all the time. And so if you are taking that burden on, you're talking about productivity loss. Lots of people have had to deputize, parents, spouses, other caregivers just to deal with the administrative burden. That has a disproportionate impact as well. And certainly, there's for people in lower socioeconomic sort of brackets, there's an impact there for all the cost sort of points that we put out earlier. And we've done some specific research into the impact of, for example, accumulator programs. And we do see a sort of sliding scale. The lower on the socioeconomic scale, the bigger the negative impact in terms of being able to remain adherent to your treatment. And I think there are copious amounts of research studies and things like that sort of show that.
In the psoriatic disease space, there's definitely evidence that people of color are underdiagnosed, because when people are trained on what psoriasis looks like, they're trained on pale skin, and it looks different in different skin tones. And then I'll echo what Anna said about women being primary caregivers for their families and the impact of these utilization management policies on their ability to work or attend to other daily needs. Carolyn Johnson in our blog post has a whole section related to sludge, where she just felt like she would put aside hours, 1 or 2 hours a day out of her workday, out of everything else she was doing, to try to make calls with the insurance company, with the provider, and connect the dots and get to her child's treatment approval quickly. And I think what I was really reflecting on was, how that impacts not only, their ability to fully show up to work, but then what about pay equity? Or if they're in a situation like this, where this is a chronic illness and they're the caregiver for family members, are they going to want to pursue a promotion if they're worried that it's going to take away from their time being able to fight with insurance companies? So that's really what stuck out to me, that is a disparate impact on women. It's just the amount of time it's taking away from family caregivers to do other things. I also wanted to comment on the person that shared their story about working for a health insurance company. And I definitely, my heart goes out to them. And I know that individuals, in all of these spaces are patients themselves. And that's one thing we like about bills like the Safe Step Act and the Copay Accumulator Act, is it should help health plans take better care of their own consumers and also make their policies more efficient. We really think these kinds of policies are win-win. So hopefully we can resolve these issues so that you and your family can get better access to psoriatic arthritis treatments, but then also so that to relieve some pressure from your job as well, because we really see some opportunities to partner with plans to improve the way they're taking care of patients.
Oh, I think that's a really good point. I want to double down on that. I was thinking about that too. There's so much nuance. I mean, certainly there are those stories and bad actors out there in any industry for sure. But there is a vital purpose that health plans play, obviously.
Oh yeah.
And there are so many initiatives that are being done, and we're reading about them all the time and having conversations about addressing health disparities, or all sorts of things that are really great and don't get as much airtime because we're trying to spend all our time fixing these problems. And it may merit sort of calling out the good players too, as we go.
Absolutely.
So I want to build on some of the points that were made. Sarah, you were talking about some of the legislation, and not that women need anything else added to their plates, especially if they're trying to navigate insurance policies. But for people that want to take action and want to see policies at the federal level change, what can they do? What should they be doing? How can they take action to try to drive meaningful change in this space?
I think the most direct way is they can call their legislators and ask them to support these bills and try to pass at this Congress and share their stories. Not everyone has their House representative on speed dial. I certainly don't. Turns out they have my number on speed dial whenever they have a telephone town hall. So an easier way to plug in might be joining your corresponding organization. So for the person that had the comment, please come and join the National Psoriasis Foundation and our advocacy work, and we'd love to partner with you. And likewise, if you have arthritis or cancer, just, you can go to the Arthritis Foundation or Google your condition and find organizations that represent patients and are involved in public policy. And chances are our coalitions are hundreds big of patient and provider organizations. Chances are that the organization representing your community is involved in these issues. Anna, what would you add to that?
I totally agree. And then in terms of maybe a different slice of your audience, if you are a health staffer who is interested in learning more or engaging these issues, to Sarah's point, there are coalitions dedicated to each one of these three, in addition to any other issue you could possibly imagine. We, as you know, I co-run one of the coalitions. Sarah co-runs one. We stand ready and willing always, want to serve as a resource to anyone who wants to engage in these issues, can find the organization, the data point, the answer to the question, whatever it may be, and kind of help connect up with the different opportunities.
Yeah, we'd love to speak with health staffers and do a deeper dive for you all on this.
Thank you both so much. And kind of as we're nearing the end of the hour, my final question is, what is the one thing that you want our audience today, whether it's a policymaker, whether it's for somebody in the patient advocacy community, or just somebody who's interested in these issues more broadly, to take away from today's discussion?
I think what I find is some people don't know that this is happening everywhere. They may feel like it's only happening to them, and why can't they get through the insurance process? Shouldn't this work? So I guess my takeaway would be, you're not alone, and come and plug in, and let's try to fix this together. So share your stories, join organizations. If you're a health staffer, I think we laid out some pretty clear bills, the Safe Step Act, the Help Co-Pays Act. Would love to have you co-sponsoring it and working with us to try to pass these, and otherwise raising this up in other discussions related to health policy and patient access to care.
Apologies, I had to go off camera, but I agree with everything Sarah just said. I have nothing to add. She covered it all.
Great. Well, thank you to our panelists again for contributing your time and expertise to this discussion. And thank you to everyone who tuned in. As Katie mentioned at the top of the call, this conversation will be recorded and posted online. And again, this is part 2 of a 4-part webinar series. So we encourage you to stay tuned for additional information to keep this conversation going. I will also plug that SWHR in the fall released our autoimmune policy agenda, which we hope will serve as a roadmap to help guide policymakers to implement some changes that could improve outcomes for women with autoimmune diseases and conditions. And we have several other resources available on our website. So we look forward to continuing to engage with you moving forward. And thank you again for tuning in this afternoon.
Thanks.